ambulances that we use in Romania are standard. No one comes and says, today I thought I want different. I want the defibrillator on the left side. No. If you want the defibrillator on the left side, you have to convince the committee in the Ministry of Health on Emergency Medicine that it is better. And then we change for the whole country. But if you want it on the left side because you want it on the left side, sorry, we want the ambulances to be standard. Because if I have a disaster and I call these ambulances to the disaster site from different counties, I want them to be the same. So that the people who are working to be able to work on each body's ambulance. I don't want personalized ambulances as a country, because personalized ambulances, it means those who know how to use them are only the ones who have them. They are very advanced. We have ventilation, we have manual defibrillator, pacemaker, everything, including anesthesia, drugs. We can put someone to sleep. We have chest tubes, everything on these ambulances. No, this is another type of vehicle we use per region. This is the vehicle for neonatal intensive care. It is run also together with the fire department and the hospital. The doctor and the nurse are trained on this. This is heated resuscitation table for the neonate. And you will see the incubator. We have around 9 such vehicles in Romania, besides the helicopters, which can transport neonates in incubators. So each one of these is in a university center. The driver is a paramedic from the fire department. And there is a doctor and the nurse which come out from the emergency department, which are trained on neonatal transport. We tried to use neonatologists to do transport. They refused it. And babies were dying on the way. So we trained the emergency doctors to do it. And the results are very good at this moment. The ambulance service receives the same equipment nearly, and this is the extra type of equipment we gave them for the house visits. Because they were going to a patient with fever, 38 degrees, they call, they want the doctor to see them. The GPs don't want to go and see them. So normally it's the ambulance doctor who goes and see them. But they were going with an ambulance, a team of 3, to consult one patient with fever. And that was loss of resources. So we bought these small cars, which have a consultation kit, for the doctors to go with them. We were planning to use the GPs from the city to do shifts and to pay them on these cars, and they refused it. And we are still fighting them since 3-4 years on this issue. So the continuity of care for simple cases at this moment is taken over by the ambulance service, because we don't have that type of continuity of care delivered by the GPs. These are the permanent medical helicopters. Besides them, we use also police and army helicopters. Months ago, it already has over 100 interventions in Romania. It's cost effective because it's faster and it's cheaper than the helicopter and it's safer. So for long distances, we have 600 kilometer distances in Romania. We send it and it is much better than using the helicopter, and the helicopter remains for the small areas. In 2007, we started the World Bank project to improve emergency departments. Normally, we have allocated for that project 35 million euros, and what we succeeded to do it is with 17 million euros, half the price, with a very strict bidding rules and so on. So you see now we have 63 emergency departments, which look nearly the same, different spaces because there are old hospitals, but where we succeeded to give them the possibility to have a much better way of work. This is Intergumureș, the new department. This is the resuscitation room. And you can see the concept. There are 3 places. Everything is coming from the ceiling. The X-ray machine is inside the room. So when a trauma patient comes, we don't have to move him. We just take the X-ray machine, we do the X-rays, and the patient is here. And just behind that, if we look, this image, it's also from that room. That door here, it opens directly to the CT scan. So you can take the patient directly to the CT scan. So there is a concept in building emergency departments. starting with triage, which is happening here when patients come. We see them if they are not critical. Even when they come on the stretcher, we know. We look at the patient. From the triage, they have one of several areas that they may be sent into the emergency department. The code yellow area, which is here, it has monitors. It is not a resus room, but it has sufficient equipment to deal with, let's say, edge patients, not very critical, but which need immediate care. The resus room for the code red. And we have also what we call the area for minor emergencies. And the helicopter pad is just 20 meters from this. So the helicopter lands, the patient is in the emergency department. And we have negative pressure rooms. We have a lot of tuberculosis. So we have negative pressure rooms to keep patients who are infectious isolated from the other patients in the department. So it's a big, big concept. Emergency departments, again, are not easy buildings. They are very special. They see a lot of patients. That department, which I was showing you, sees also pediatrics. And there were reasons for that. We have 2 telemedicine systems, which maybe they are amongst the most advanced systems at this moment, not maybe in Europe, but in the world, as an extension. This is the machine we use for pre-hospital. It has a place where we put the card, and this is where we receive the data in the hospital. The system is, the construction of the system, we started in 2003 by a pilot project, funded by Vodafone at that time. And then when we saw it's working, we took over and we started implementing it at a governmental level, when we bought the ambulances. When we bought the new ambulances in 2007, we included the telemedicine solution into them. So the price of the ambulance didn't show, in fact, the cost of the telemedicine, because it was anyhow, because of the volume, cheaper than the ambulances in Germany, even if they were German ambulances. But they included the telemedicine solution. And to make the running of the telemedicine solution cheaper, we called upon our special telecommunication service from the government, and we asked them to run it for us. So the whole fleet costs us per month €1 per car, and for the whole fleet of ambulances, €360 per month. And we can transmit that as much as we want. For the inter-hospital system, the cost is per hospital per month €200, which is nothing for a hospital. So the idea is that we classified our hospitals into different levels. You cannot have all your hospitals the same. So we have regional level 1 hospital, like the one in Turgumuresh, which has all specialties. You have level 2 hospitals and level 3 hospitals. What's the difference between them? Here I have neurosurgeon. Here I don't have neurosurgeon. Here I have neurosurgeon, cardiac surgeon, pediatric surgeon, I have everything. So there is a classification which says each level of hospital what they have. And for example, these 2 hospitals would be sending the patients which are beyond their competency to this hospital here. The small level 4 hospitals would be sending the patients, until recently, to the hospitals in their counties. Let's say this is a county. So they were first sending here, and then the patient was coming here. So let's take this small hospital or this one. If the patient is a multi-trauma patient, why should they send them here because it's just a county hospital? Why not send them directly here, where the patient should arrive? So this is what we are looking at, changing the system, and the telemedicine could help us with this. An ambulance, if this ambulance took a critical case, the idea was that it goes to the nearest hospital, but the nearest hospital is a lousy hospital which doesn't have anything in it. They got the patient, and they started sending them to the X-ray to see if they have a fracture, and the patient was in fact suffocating because they didn't have sufficient air, because they had a pneumothorax or something else. So what we were saying is, instead of this patient going here, then going here, and then from here going here, why not, using the telemedicine, we can see the patient, we can decide, and this patient can come directly here by ambulance, or we can send the helicopter. And this is what we are trying to do. There is a study in the United States which shows that if you pass by the less competent hospitals and you go directly to the hospital you need to go to in trauma patients, the chance of survivability increases, or let's say you drop the deaths from trauma by 25%. So this is a very important number. You don't have to stop in a hospital which cannot do anything. So in Bucharest, what impact the telemedicine had? For myocardial infarction, we have 5 cath labs for stenting. The problem is they are not all the time on duty. So today this is on duty, tomorrow this is on duty, the day after tomorrow this is on duty, and then this comes, and then this comes, and then this comes. So if I have a myocardial infarction in Bucharest, and I go to the wrong hospital, I'm losing time. So what we do, the fire ambulances transmit to the fire department dispatch where we have a doctor, and the national ambulance, they transmit to this hospital. They do less transmissions. Nurses don't like to transmit data, and we are forcing them now to do it. And once we see that it is a STEMI, it is a myocardial infarction, the dispatch will immediately direct the ambulance to the center which is on duty. So if this center is on duty, they will tell them go there. If this is on duty, go there. If the other is on duty, go there, and so on. We did another thing. I will talk about funding immediately. But besides the funding of the emergency system, we started also co-funding certain activities. So, for example, for myocardial infarction, we saw that the insurance company doesn't pay sufficient money to cover all the costs, and this is why less than 15% of our patients were stented in the good time. So what we did, we started paying to the hospitals through the ministry directly the money for the consumables and for the stents. In 2 years and a half, 3 years time, from the worst mortality in myocardial infarction, 13.7%, we dropped to 8.4% in about 3 years. In the centers which do the stenting, the mortality dropped to around 5%. And we have now over 55% of the myocardial infarction patients getting stenting immediately or within the first hours. So there are several centers in the country which do this, but here you can see what I was talking about. Until we started the project with the Ministry of Health, this is where we were. And immediately this dropped down, and this is the stenting level, which we got nearly to 60%, and the mortality dropped down, as you see. And it's still dropping. This is the data from 2012. We have new data from 2013, which show that this is the data that now, this is level we are at, around 8% the mortality. So let us see how the telemedicine system works. For example, this is the third center, Yash. This is the modern equipment they have. They had a child born, or a patient, which they were thinking they have myocardial congenital malformation. And the doctor from 180 kilometers called them to look at this. And you see, this is the doctor who's specialist in this, and she's looking at the ultrasound, which is 150 kilometers away, to take a decision. And the idea is, you can connect even the ultrasound to see the full screen here, but because it's high definition camera, you can see the same thing here. See, this is the joystick with which they control the camera in the resus room. This is the hospitals that they were connected to at that time. And you can see the doctor here can zoom, can consult the patient, they can talk to a paramedics team, they are discussing a case with them. So it's even for educational purposes. I will tell you how we built this system. I told you that the emergency department's cost was initially 35 million euros, and we did them for 17 million euros. All the money that remained, which was World Bank money, we invested it in other projects in emergency medicine. And one of the projects is telemedicine between the hospitals. We did 11 more projects, and one of the projects, so this was done from the economies we did on the equipping of the emergency department. So, let us see a real case. I was on duty on the helicopter, 2010. I still do shifts on the helicopter. And I got from the Ministry of Health an SMS telling me there was an accident with 2 dead, 1 child ejected from the car in an area in that region. So I called the hospital in Turgumorish. I was in another intervention, asked them, did they call you? No, call them. So they called them. And what they saw, the child was taken by a private car to that small hospital, which has a GP on duty. The child had a fracture of the femur, a fracture of the tibia, and he was ejected from the car, but no collar, nothing, no protection. So, and the doctor wanted to send him to the next hospital in their county. So our doctor interfered. He told him no, and he started telling him what to do, and the helicopter went and picked up the child. And it was in less than 1 hour the child was in the main hospital, which has pediatric surgeons, orthopeds, which can work on him. Otherwise, he would have lost 2 to 3 hours, and he could go into shock because of that. In the pre-hospital field, this is a resuscitation run by the fire department. They have the defibrillator, they are ventilating, they are doing the cardiac massage. You will see that this guy will be changed immediately with another firefighter. He's tired and he's not staying properly, and you will see the doctor will tell him to change immediately. The doctor in the hospital is seeing this. He's working with them. There is a medical unit on the way, but they are 60 kilometers away. And we are helping. So the doctor virtually is with them. So now what we are saying, we want to train the firefighters to have access to IV, to give adrenaline, to give drugs, on the indication of the doctor. The doctor is responsible. The firefighter will be only the executor. He will not be responsible for this. So, but it is good for the patient. You see now they change. He's doing very well his work, and they are following up until a decision is, until the doctor arrives or the medical team arrives. And you can see they are nowhere. They are between 2 villages somewhere. Of course, when we are building a system, we need to think about costs and time. These teams can be created very fast. 6 years plus 5 years of specialty, 11 years. So, when you build the system, you need to think of fast development at a lower level of competency and slow development for the higher level of competency. And you have to look at the costs, of course. Disaster response is part of the system. We don't have a system for disaster response, but we have special equipment for the disaster response. We buy them by the Ministry of Health, but we give them to the fire department to manage them. And we use them together if there is a disaster. So how we do it? This is what we call advanced medical post. It has equipment for about 40 patients, plus heavy rescue equipment. We should not forget Romania is a high seismic risk area, especially Bucharest and some other areas. So there's also rescue equipment in it. It's a standard vehicle. It has tents in it to do a mobile emergency department. Now, we also have other types of special equipment for CBRN, for example. Decontamination for chemical, biological, radiological, which is done together with the fire department. This is the tent for washing people contaminated. This is the special vehicle for contaminated patients. So we do a lot of exercising on this. We train our people, we do regional exercises, these are the vehicles we use for mass evacuation. There are special vehicles which we use them also to go for areas which are very hardly accessible. Another special vehicle, we introduced it only last year by donations, not buying it, but now there are a lot of areas buying them, are these small vehicles for snow areas. It has a stretcher and it is carried by the fire department. This vehicle saved 35 people among which women who were giving birth last year in blocked areas in Romania. So they have good things from our point of view. We can use them in floods and we can use them in snow. And they are much cheaper because there were counties in Romania who wanted to buy military vehicles like tanks, which cost about 300,000 euros a one. And we said, no, we take easy ones, which we use them 1 month a year or 2 months a year. So we went to these which are much cheaper. You can buy 10 ones for the price of one of that. So again, it's the same concept. Normally, each one comes with their command vehicle. The ambulance wants their command vehicle. The police wants their command vehicle. The fire. But again, we are managing the same resources. So the idea is to integrate the management more, as we were talking before about the central dispatching. Communications, which have all communication networks for all the services. The work with the police and the army for mass casualty incidents, as I was telling you before. So if we have this for example was an accident with 11 people and we had to transfer 3 of them. So we called a military helicopter which can take 3 stretchers. But we gave the medical personnel. So it's a joint work with them. We created 6 centers for training in ultrasound for emergency doctors. And each resident in emergency medicine now must be trained on the ultrasound simulator, because I want them to know how to put a diagnostic of a cardiac tamponade. I don't have every day a cardiac tamponade in the emergency department. It comes once every 3 months. So if I'm training 10 or 15 doctors, some of them may pass 5 years without seeing one. But if I have these simulators, I can show 10 times for them in 1 day. Because it's there. And I can train them. So the training is extremely important within the whole system. Human resources are the most important. They are more important than cars, than helicopters, or than anything. This is one of the most modern training centers. It has 3 issues. Simulation, real simulation, and it has as well virtual simulation. Through European funds, we introduced a simulator for disaster management. And here we train fire officers, doctors, nurses, police officers together. What we spend is between 5 and 6% of the whole health expenditure in Romania, which is a very reasonable amount. If we are talking about around 2,400,000 cases in the street, including simple transports up to major emergencies. If we look at the emergency system, it deals with around 7 million cases. Some patients from the street may be also here in the emergency department, but it's 2 different situations. You treat them in the street, you take them to the emergency department, then you continue in the emergency department. So it's a huge number that this system is dealing with. And the funding is coming the following way. We used to have the ambulance service under the insurance company until the beginning of this year. We took it to the state budget for 2 reasons. One, because we don't care if you are insured or not. We go to you, whoever you are, whether you are poor, whether you are rich, we go to you. We don't ask you, do you have money or are you insured? So we took them from the insurance to the budget. The second reason is that the insurance company tends to go for the principle, I don't care who's doing the service. I pay anyone, even if they are a taxi company, if they have an ambulance. And they were risking in the future to privatize the whole system. So we took it to the state budget, because in the state budget we can control what we are funding. What we left at the insurance company, the National Insurance Fund, is the funding of the private ambulances for transport and for house visits. But We told them you cannot work alone. You have to be coordinated by 112. And only if we say that you did this case, they will disperse you for it. Because we had companies which started doing their own, and the number of calls increased hugely. They were going to one house, seeing one patient, and then they were saying, you don't look well, let me see you also. Does your neighbor want a doctor? And they were going out with 3, 4 calls instead of one. And saying to the insurance company, give us the money. So now we told them, no, we send you for the house visits and for the transport. And when we say we sent you, you get this money. So the ambulance system is now from the state budget. The hospital itself is from the insurance company, but the emergency department is from the state budget. Completely, including salaries. We give the money to the hospital, but we monitor them how they spend them. We have checkings nearly every year, huge monitoring in the whole country on how they spend the money. We catch them if they are spending them incorrectly. We ask them to pay them back if they didn't spend them correctly, and things like this. So, the SMURT system, the integrated system, is funded through 2 sources. For the medical activity, it's coming from the emergency department, which is state budget. And for non-medical, it's coming from the Ministry of Interior, from the fire service, and from the aviation inspectorate. But it is very clear in the law, each one of us on what we spend. No double spending. So, from the emergency department, we give to the fire department all the medical materials, the consumables, and so on, and we replace them for them. And it is on the state budget from the Ministry of Health. But they get from their ministry the money to maintain the vehicles, to pay the fuel, and everything they need for their staff. We're not a taxi called to do a service to take you from here to here. We are people called to help you, and we are forced and obligated. We cannot refuse you. So it's not just rendering a service. We cannot refuse you. We have a task given to us from the Parliament, from the government, and so on. So, as I said, Ministry of Interior through the fire department, the aviation, Ministry of Health through the emergency department, now as well the ambulance service, and the National Insurance Fund only here and the hospital. But also from the Ministry of Health, we are giving to the hospital now money for co-funding for the myocardial infarction program, and for the intensive care units, not the emergency departments, but the intensive care units. Because they don't have sufficient money to buy consumables and materials. So we give them extra money from the Ministry of Health, and we follow on what they are spending them. We have eligible cases where we say, for these cases you will get money for materials, for drugs, and so on. And this is improving a lot the quality of these cases. Next year we are starting a co-funding for trauma, for osteosynthesis, because this we have a problem with the funding also from the insurance, and for cerebrovascular accidents, for thrombolysis, and for neuroradiology. And these will be the main actions that we will fund together with, we will co-fund with the National Insurance Fund, but we control them from the Ministry of Health. We have a department in the Ministry of Health, which I'm responsible for it. It's called the Emergency and Strategic Programs Department. And this department is responsible for the funding and the follow-up of the funding we give from the Ministry of Health for the emergency system, as well as for the myocardial infarction and so on.